important to highlight, though, is I think this reflects what Lewis said, too. This population isn't getting as sick as the older population, but they are still playing a major role in transmission. So this actually goes back to the previous question, too, when talking about how long people are infectious. One of the things that is a continuing public message, regardless of whether we're in a COVID-19 pandemic, is to stay home when you're sick. And that is not only when you're post-positive test, whether you're symptomatic or asymptomatic, but when you have symptoms, particularly that are suggestive of COVID-19. And so we really want to continue to push that message for younger people to really take care of their health and play a role in reducing community transmission risk.
Yeah, and Hawk, one of the things we know, young people tend not to get as sick from any infectious disease process because they're young, and you and I were, I was young once. Maybe you're still young. I don't know. But I'm no longer call myself as young. I like to think I am. And then my knee hurts, my back hurts. But the truth is that even though people who are younger may not get as sick as frequently, they can still get very sick and die from this. And we've seen that nationally. I think to follow up on Catherine's point, as the disease shifts from an older population, which is where it was initially, or even middle-aged population, because we were in an older age population that had nursing homes, then it was a middle-aged population. Now it's in a younger population. That's where most of the spread is. The question is going to be in 2 or 3 months, how many young people will have been in the ICU or suffered some other problem from the illness?
Yeah, that's a good point. We've said all along that young people don't get as ill, but I think within the last 7 to 10 days, we have had a 30-year-old patient in our ICU, so they do get ill. And to Catherine's point, we get this question as well. Why are these people, it doesn't seem like they're getting as sick? Is there a weaker strain out there? Again, there's no distinct other clinical strain. There's one strain. But why aren't people getting as sick? Well, I think the young population is one of the big points. But also another thing that's being thrown around there is with mask use. So one of the reasons why we think people get sick, there's consideration for the infectious dose. How much virus are you being exposed to that's making you ill? Is it just a little bit of viral load, or is it a large amount? And so the theory is that if you have a larger amount of viral load that you are exposed to, that tends to be able to overwhelm your immune system for a little bit, and then your immune system comes back strong. We know about the cytokine storm and the immune dysregulation. Whereas if you have a smaller infectious dose, you are able to cope with that more. So that's one of the other lines of thinking. And what is the main thing that is leading to lower infectious dose or lower exposure? It's mask wearing, and it's social distancing. So we have been doing that as well. So that is one of the other theories behind why there aren't as many deaths or hospitalizations. In addition to when people do come to the hospital, we have better treatment algorithms now. We have things that we're using to help you. But that is one of the one of the theories that people think, well, why aren't people getting as sick as the virus changed? No, I think it's the other things that we're doing, the public health guidance and the treatment algorithms that we have.
Yeah, so that makes sense, and hopefully young people will stay less sick. But I did see there was an article yesterday that talked about masks are the new vaccine. That for just that reason,
that was it.
You're getting a little bit of exposure, not a lot of exposure at any one time.
Yep.
So okay.
So this next question is for Dr. Satterwhite, Catherine Satterwhite. Catherine, with all the work done by the CDC, state health departments, and local health departments, will it be helpful in planning for the vaccine distribution?
Absolutely. And it's actually, I'm glad that question was asked, because I think one thing that I wanted to mention during this morning was all the work that those particular groups are doing. Like the medical community, the public health community has worked tirelessly over many, many months with the same staff continuing to advocate, to plan, to figure out how we, the public, are going to come out of this on the other side. And there will be another side. But yes, all the work they're doing is critical. It's an ongoing process. Just like was mentioned at the beginning, there are things that come up. The data safety monitoring boards really thoughtfully and critically approaching these trials in an ongoing basis. So as we learn more from the trials, we'll learn more about how to plan for the vaccine distribution. So it's an iterative process, but state and local health departments are really well positioned and doing a great job to prepare.
Yeah, I think that's. Go ahead, please.
Catherine, fair to say that there's a lot of work ongoing for the parts of that logistical challenge that are known, and those are being done in advance, but also there are several parts that are unknown, what date they'll be available, if it will be one manufacturer versus multiple manufacturers, the manufacturer that is available first, what their capacity is for volume of distribution, and so there's a lot of the logistics that can be done in advance, but a lot that will really need to be individualized to what's available in that moment.
And I take it then, I think you kind of hit on this too, Catherine, earlier, is that first responders or frontline healthcare workers are probably people who are going to be the most at risk for exposure, so they'd be up there with people who are have some significant chronic illnesses for vaccine distribution. Is that sort of the logic?
Yeah, that is the logic there. And there are a number of possible priority groups, including frontline workers, essential workers, including nursing home populations, both staff and residents. So yeah, there are a number of populations that are being considered for prioritization, given what vaccine efficacy looks like once the data are available, given how much is available, what the distribution likes, a number of things.
Have you guys thought about what will happen if you have 2 or 3 vaccines? How will you decide which one to use? Because it could be coming out early or whatever.
That's a good question. I don't know that I have a good answer for it, but I'm sure that people are thinking about it.
And so we're hearing that, geez, maybe there's going to be a rush to try and produce something by Election Day. But then you read the CDC and these companies say, gosh, we're not going to do that. We're not going to rush. Thoughts about that at all, Catherine? Not that we're trying to put you on the spot or anything, but that's a tough question.
No, I think you and Dana summarized it well. That can you guys hear me still?
Yes, we're hearing you.
Okay, sorry. You summarized it well in that even though we have tried to speed up the different steps that it takes to get a vaccine to a point where we're confident in the safety and how well it works, you can't take shortcuts on figuring out whether you're going to administer this to a population on the whole. So yes, we're going faster, but we're not taking shortcuts that would prevent the integrity of this process.
Yeah, good thoughts. And Dan, I know that's how drugs get studied all the time.
Yeah, absolutely. And again, the biggest thing is safety. The second thing is efficacy. That is being worked on. So far, they do look safe, from those initial published trials. And that will be the main concern, and I know that's the main concern of Dr. Fauci and Dr. Birx and everybody. So there's already enough of a voice out there who don't want to get proven safe, efficacious vaccines for easily preventable childhood vaccines and other infections and other adult infections. There's no reason to risk that in this case either, because we want to continue to promote vaccines. They are healthy. They do save people missed days of work, which is important for almost everybody, hospitalizations, severe illness, and even death. So
the pause of the clinical trial is an example of the system working as it should.
Yeah.
Right. Again, I use the example of if you're in a heart drug study and all of a sudden you have a heart attack. Well, that's not surprising. You're in a heart drug study. And so you have a heart attack. The question is, did the study cause it, or did you have a heart attack because you have heart disease? And I think that's what's going to happen. And all these studies have to be monitored, whether it's a vaccine or it's a new treatment or for COVID-19 or any other disease, whether it's an antibiotic.
And it happens for antibiotics all the time.
And then sometimes even after you get the data, you've done all the studies, you can find out a drug can cause the damage. Those of us who are old enough remember trovafloxacin. Trovafloxacin was the new cool antibiotic therapy. Up there was Cipro and Levoquin and all these things we use all the time. And all of a sudden, after we started using it, we found it caused liver failure. And so it got pulled from the market. So lots of things go on to making sure drugs are safe for a long time. And even after a drug or a vaccine or anything is approved, they continue to have to be monitored. It's not like just because the drug's approved, you stop monitoring it. Actually, you keep right on going. You have to report all those events. So.
Dr. Seitz, Donna wants to know, do you know why KU and Lawrence is cutting back on testing its students?
Yeah, I'm not sure that I would have said they're cutting back on the testing of the students. I can verify that today. But I think what has happened is we did the initial screening on everybody. And then after that, what happened was there's supposed to be periodic surveillance testing, which is going to be ongoing. And then there is acute testing. And I think one of the things that was occurring is that there were enough people with symptoms that needed acute tests that was getting a little too busy. So the health system's going to step in and work with KU Lawrence to help make sure all those tests get run. So I think in the long run, it's not changing. I don't believe the algorithm's changed. I think that there's more demand.
Yes.
And so as a result, like I said, the health system and the University of Kansas are partnering together to make sure we get that demand meet and everybody gets a test. And we hope to have that ready to roll out by the end of the day. You know, we put swab clinics out. We've got one here. We got one over at the Indian Creek campus. I think we're going to put one on the Lawrence campus. And LMH is opening up and more swab clinics in within their area as well. So lots of effort to make sure we're able to do those.
Kim asks, when Dr. Hawkinson mentions lower numbers each day, what do lower numbers mean for our community overall as we head into the fall?
Oh, that's a great question. Yeah.
Because there's a lot of numbers.
There's a lot of numbers, a lot of stuff wrapped up into that question, actually, because we'd have to talk about what we know on our CMO calls, our Chief Medical Officer calls, that we know the counts across the city, and we have another call on, I think, on Thursday. And so we'll know more about that at that point. But there are also ways to get daily numbers from hospitals that you can see. So comment a little bit about what our lower numbers mean.
Yeah, and Lewis, we are usually on a ICU director's call that he
leads.
He heads up. So he was on that today as well. So the numbers are different. When I talk about lower numbers in general, it's the number of people who are being hospitalized for acute COVID-19 infection in our health system. That includes people who go to the regular medical floor and go to the ICU. I also talk about lower numbers in general in the Kansas City area, mostly about the rolling 7-day average rather than the daily numbers of infections. So that is the main, those are the two main numbers that I talk about. And certainly we would like to see zero. We would like to see 0 cases, 0 hospitalizations. That isn't happening, but it is certainly better than up in the mid or high 30s that we were, say, 2 or 3 weeks ago. So that is the main thing about the numbers. In addition, there are the county numbers, Wyandotte County, Johnson County, the state numbers of the whole state of Kansas, where, again, we've talked about individual infection dynamics in your community because they are quite different no matter what county you're in. We saw this past week or 10 days in the counties that have the college campuses. They seem to be quote-unquote hotspots because their percent or number of cases per capita is rising compared to other counties. So those are the main numbers that I talk about.
And what we don't know yet is how the rise in some of those campuses numbers are going to affect the hospitals. We just don't know that relationship yet. Because again, back to the earlier question about young folks not getting as sick as older folks, that's still something we'll have to wait and see that goes on. And the impact of mask wearing, which may have been you got sick but you have a lower inoculum. There's just a lot of variables moving out here. The key is, how do you stay safe? And the answer is you stay safe with the pillars of infection control. Kat, anything you want to add to that?
Yeah, actually. So it's really interesting. The college campuses, a lot of them are screening their entire student body, like what KU did. So the case increases that we see in some of those areas are sort of due to screening. They're detecting existing cases. They're not necessarily new cases. But it does remain to be seen how that will impact the community transmission, as a lot of these students come from their homes into this other, oftentimes smaller, college town. So it is something that we're actually looking at the federal level as well.
Yeah, one of the reasons we moved for mass testing of all students is it really is mass migration. You just put 25,000 people and plop them right into a whole community that had its own disease incidents and its own public infrastructure. And those kids are often living together in close quarters, and they go out and they shop and they go to the restaurants and the bars and do whatever. And so there's a transmission, but it can take weeks, even to months, to see what the real impact of that is in a community. So one of the reasons we wanted to do mass testing was to identify those kids early, get them quarantined, and slow the spread so we don't overwhelm the healthcare systems in Douglas County. And I think that's been absolutely the right thing to do. I think we've been really helpful with that. we won't know the impact of opening schools and opening colleges for really several months, because it takes a while for who spreads it to who, and for it to get to an older population who tends to be sheltered in. Then it's just going to take a while to figure that out. So we can't declare victory yet. All we can declare is careful surveillance.
Yeah, we have to stay really vigilant. I appreciate what you say about one person exposing another. And then there's the clinical lag, the time between exposure and when someone might become mildly ill or severely ill. Sometimes that severe illness is delayed quite a bit after exposure. And we don't know that number of days exactly, but it's oftentimes more than a week from the time of exposure to the time where we're really seeing a worsening in the clinical status. So beyond possibly one person transmitting to another, even after you make an intervention that increases or decreases exposure, we don't see that impact on hospitals until quite some time later.
Exactly. To borrow the term from Harry Potter, constant vigilance, Kat. I thought you started to say something there.
This is why it's so important to do your 3 pillars, right? That no matter what, you're wearing a mask. You're staying away from people. You're avoiding those large gatherings. And just being really thoughtful about your day-to-day activities. And it's especially important for all these college kids coming in as they start to interact with the community around them. Wear your mask. Stay home if you're sick. And avoid those large gatherings. We know that there's parties, and we know that they're going. So we need to try to reduce some of that.
And we know that those parties became hotspots, and a whole bunch of people got quarantined at KU, and all of a sudden things have gotten better. And just to say, mask wearing on the Lawrence campus is outstanding. And I think 99% of people at the time, people had their masks on. So we've done some what do you call it? Secret shopper look there, and the mask culture on the campus is great. So rock chalk for that.
You may have touched on this, but I wanted to clarify for Valerie because she's asking. She says, my son has contracted COVID and is in isolation in Manhattan. When he is finally able to return to his house and roommates, are there extra precautions he should be taking? Is he at risk for contracting it again?
Oh, that's a great question. So glad Hawkeye's here.
Well, again, continue to be isolated for 10 days from when your symptom onset was or when you had your diagnosis. I think the longer, the better. But when you do go back into society and you are around people, you have to continue to do the things that everybody else is doing, and that is masking. Try not to be gathered around groups of people, especially indoors. So do the physical distancing, do the hand hygiene, all those things. Can you get it again? Well, we've obviously seen new cases of reinfection in very well done studies that actually looked and saw that the viruses were different on the genomic level. So you can get it again. How soon? We don't know. There have been speculation of a few weeks to more than 3 months. There was an Icelandic study in the New England Journal of Medicine that looked like you had protection for at least 4 months or so. But you will find variability. Again, it is human biology, so you will find variability in the individuals. But for the most part, yes, you can probably get it again. Will you have mild or no symptoms, or will you have worse symptoms? That is a question that isn't fully answered, because both of the 2 documented cases, one had no symptoms of disease, where the other one was actually more ill than he was the first time. So continue to do the things that we've been talking about: masking, stay out of crowds, physical distancing, do the hand hygiene, and that will keep you safe and others around you safe as well.
And to put a fine point on it, because you mentioned earlier we only have one clinical strain, and then mentioned that we have people that have been documented that they've had a virus twice with differences at the genomic level, and those 2 things are consistent. You can be able to prove that it's a separate lineage of a virus and not a reactivation of the same infection they had before, but clinically in terms of a strain and what it means on that clinical level, we've only really seen one.
Yeah, excellent.
So I think what we're saying
point.
is, if you've had the virus, don't get cocky and think you can't get the virus again, because you may well be able to. Probably you won't get as sick, but we know the guy in Nevada who got sicker the second time around. And so I think that we just, there's so much we don't know. We've described it before. Building the airplane while you fly it, that can be a challenge.
Julie asks, if you get the flu vaccine and get a reaction of fever or body aches, should I automatically rule out COVID and just isolate or quarantine for a while?
Wow, that is a great question, Hawk. it's pretty typical to get those symptoms right after you get that flu vaccine. They usually go away with that. I think if you get a vaccine and you get the symptoms for 48 hours, you probably don't need to run out and get a swab for COVID.
Yeah, that is going to be a difficult thing moving forward for sure. But to your point, we know that people can get symptoms because it is their immune system interacting with the vaccine, causing that type of symptoms, so that you do get immunity. But I think, be careful. But looking in the 24 to 48 hours after the vaccine, it could just be a vaccine.
So let me ask you, would you tell that person to quarantine or not go to work? I'm sitting here thinking, what would I tell them? I'm hoping you got good advice. We're going to take a poll here and see what each of us would say about that.
I think that depending on what they're doing, what their bubble is, where they're going, we know you can get it in the workplace, even if you're otherwise being very vigilant and not going out, being in large groups. If there's testing capacity, I would probably, recommend to get a test, especially if the symptoms are lasting more than 48 hours.
Okay. What would you do?
So I think we'll need to create clear messaging on this, and I think it's a great question. I appreciate that question because it will highlight where we need to be very clear in our messaging. I would say that if it is within the realm of what could be expected after the flu vaccine to quarantine just for that short period of time. I mean, oftentimes we're talking about 2 weeks of quarantine, and I don't think that would be necessary if you have symptoms for 24 hours and it goes away. But it really to be thoughtful about where you have to be during that 24 hours and be respectful of your people, all the people that you interact with on a daily basis, and try to avoid being out and exposing other people. And the likelihood is that it will be just related to the vaccine and that it will go away and that you'll be able to get back on with your routine.
Catherine, what do you think? Because this is going to be a public health question because it's going to happen with the COVID vaccine as well.
Yeah, I'm actually going to email CDC after this and be like, hey, who's working on this? No, I have two things. One, that it should be a conversation with your medical care provider. And if you're worried about it, you should call them. The second thing, the timing of the symptoms matters. I think if it's happening 12 hours after or even a few hours, the timing matters. So in consultation with your medical care provider, think about the timing of the symptoms.
Yeah, here's what I'm going to do. I think I'm going to be taking my Advil, and if it breaks through, I'd probably go call and talk to somebody.
And I was about to say, I think we've all thought differently about the headache that we get at the end of a stressful day, differently than we did a year ago, and that's part of where we are right now.
And I don't know if this has anything to do with it, but I think if there's a local site, injection site reaction and more pain, it's probably more related to the virus. But I think that is one of the, just like you said, we need clear messaging moving forward.
Yeah. All right.
But clear messaging is we need those people to get flu vaccines.
We have a whole pandemic advisory group here at KU. We're going to take it back and talk to them. This is a great question.
Okay,
last question.
Here's a really good question. Vicky says, realistically, how long do you think we will be dealing with this pandemic? Will we ever return to normal, or is this just our new world?
Oh, man, that is a great question. Well, I have rose-colored glasses on, so here's what's going to happen. We're going to wrap up today's session by answering that question. Catherine.
Can I want to pivot.
Oh, you go right ahead and pivot, and then we'll come back.
And here's the thing. So I don't know how long it's going to last. I think that we're doing the right things at the right time to try to figure out how we're going to get to a better place. Part of that, and this is what I really want to make sure I mentioned, because Dr. Hawkinson brought this up. Part of that is not delaying things until you think this is going to be over. So if there's medical care that you think you need to talk to your healthcare provider and you need to get it. One really important thing is vaccines, all the other vaccines. So the flu, super important. Get your flu vaccine. But if you have kids who are behind on their vaccinations, call your medical provider, figure out how you can catch up. If you're an adult, you need to double check on your vaccinations too, because we need to keep ourselves as healthy as possible so that we're better able to see what comes next and that we'll be in better shape when this is over. So,
yeah, that's a great answer. What are you thinking? I
don't think that this is a new normal. I do think that where we end up 1 year or more than that from now might not be the exact same as it was in 2017. I don't think it'll necessarily be exactly where we are today. So it's a little bit of a non-answer. I do think that this will forever impact our lives and our society to some degree, but I also think that the precautions that we're taking today are needed now, and that with advances, vaccines, therapies, and other knowledge about the science will allow us to return to things that we're not able to do right now, but there might be some precautions that we take forever going forward that were not part of our daily lives prior.
Yeah. I don't know that I have the rose-colored glasses you do, more of a practical approach. You know, the virus will be with us, is my opinion. But in what manner? Just like you said, things are evolving quickly. Therapies are evolving quickly. Vaccine development is evolving quickly. Is this just the first generation of vaccines? Will there be second and third generations vaccines? But also, is our young kids who, again, we've talked about younger people not getting as ill, as they start to grow up through this, what is their immune reaction going to be like? Are they going to have it more to where it becomes like the normal coronaviruses, which cause the common cough and cold? We just don't know that yet. So moving through, but I think certainly for the next 6, 9, 12 months, it will probably be similar to what that is. But then you also have to include, what are the social norms going to be? What are people going to stand for? Are they going to stand for another shutdown? Are they going to continue to get out? It probably won't be like last February when the Chiefs won the Super Bowl and everybody was out and crammed together partying, unfortunately. But in some way, it will change from what it is now. But I think the virus will still be with us. We just have to figure out in what manner. Also, our treatments may evolve and probably will evolve to where, you know, if it's anything, it might be just like a sinus infection where somebody gets an antibiotic and they go home and in 48 hours they're feeling better. So there is still a lot to evolve. There are a lot of questions that aren't answered. But right now, the virus will probably be with us. It's just a matter of how is our society and our culture going to deal with that.
Here's what I hear in that question. I hear an ache. There's an ache for the things you're missing. I call that COWS, COVID weariness syndrome. But there's an ache. And what you are really thinking, that the listener who has asked that question, there's an ache for what's normal and an ache for the things that you miss. And I think we're all aching a little bit. I think we're going to be aching. I'm going to be aching when I'm watching the Chiefs game on Thursday night. And gosh, I wish we could be at Arrowhead. I wish the parking lot was full. I wish the crowd could roar when Mahomes and company roaring under the field. Mm-hmm. And we miss those things. We miss those things. I think we'd miss each other more if we weren't here, though. And that's why we preach those pillars of infection control. This is not forever. It's not a new normal. It's a new abnormal. And it will pass because we will have therapy for it. And we will have vaccination. And we've talked a lot about vaccination, but the therapeutic aspect of this may be more important, which is if you get sick, we can take care of you. So I think that's on the horizon. And I think a year from now, this is going to look markedly different than it does today. Now, I have a prediction. My prediction that is an opening day at Royal Stadium, there's a whole bunch of people in that stadium. I hope to be one of them because I love that team. I hope that there's going to be people that will be back at the Chiefs games full throttle next year because Arrowhead is the loudest stadium in the NFL. I hope we're able to go do those things and get on the road and see the people we want. It may still be a little different. We may still have to be a little more careful with infection control, but it'll get closer to where we were. It may never be exactly as we were, but it's going to get closer. This is not a new normal, and even today is better than it was 3 or 4 months ago. And our patients in the hospital are already doing better than they were because we're smarter about things like Decadron or prednisone steroids and anticoagulation and remdesivir and convalescent plasma. We're already getting better. So the future is not the past, not the immediate past. It looks different than that, and that's a good thing. Hey, I want to say thank you to Catherine and Louis Satterwhite. They're awesome. You guys are coming back. That was way too much fun. Tomorrow will be fun, too. Dr. Jamie Wagner, who's the division chief for breast surgery and breast surgical oncology here at the University of Kansas Cancer Center, and Dr. Ron Chen, the chair of radiation oncology, are going to be here to talk a little bit about the impact of COVID and cancer and how you can stay safe and still get your cancer treatment, which is incredibly important. I also want to say thank you and a reminder to everybody to send us those mask photos. Otherwise, we're going to have to show more superhero videos, and gosh knows nobody wants to see that that pow, clash, bam thing again. But also, we want you to tell us the reasons, besides safety, that wearing a mask can be useful. As I mentioned, I didn't brush my teeth. I've had a bad lipstick day. Actually, I don't wear lipstick most days. Or a bad shave day, or a bad zit day. I mean, all those things can still happen to us, and masks can sometimes help us. So, again, a special shout out to Catherine and to Lewis for joining us, Hawkeye, and to all of you out there. Remember to stay safe, and there's still no place like home.